So I'd like to humbly acknowledge that we host this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, Squamish, and Tsleil-Waututh nations and the Métis Charter community of the Lower Mainland region. You, wherever you are in this province, are joining from your territory, and I urge us all each day to reflect on the land and the people and elders past, present, and emerging. Next slide. I'd like to also acknowledge that Province-Wide Rounds is a collaborative effort by UBC Division of Nephrology and BC Renal. As well, we acknowledge our wonderful industry partners, as well as all of our health authority partners, without whom both attendance at this, but also the transfer of knowledge and commitment to improving outcomes of patients would not be possible. So thank you all for what you do. And now it's a really great pleasure to introduce Drs. Karen Shalansky, Kevin Kwok, and Hilary Wu, who are clinical pharmacy specialists in nephrology based at Vancouver General Hospital, working in the across the renal program there. And they're going to speak to us with a combined program of work looking at the safety of IV iron products and a review of Ferric Derisomaltose in CKD patient populations. So with that, thank you all for your attention and interest, and I'm going to pass it over to Dr. Shalansky, I believe.
Okay, thank you. So today we're going to talk about three types of IV iron safety issues. First, looking at infusion-related reactions, and I'll go over the differences between the three IV iron products in Canada and why their maximum doses differ. We'll discuss the study that we reviewed on the safety and efficacy at VGH of Ferric Derisomaltose and monoferric. And then we'll look at infection risk of IV iron. Is it associated with the risk of causing infection and can be administered during an infection? So once iron is absorbed, it is bound to transferrin, which is the transport iron, and it transports it primarily to hemoglobin, to the bone marrow to create hemoglobin, and to ferritin for its storage. The clearance is zero order, which means it's capacity limited. So if you overwhelm the transferrin transport system, then we have free label iron, and that can cause oxidative stress and inflammation. So once patients are iron deficient, then we usually replete them with hypo. Our repletion dose is usually at that. So just going back to this slide, so you can see that transferrin is capacity limited and saturable, meaning that if you have too much iron in the system and it gets saturated, then free iron is what causes this oxidative stress and inflammation. So our repletion dose of iron is anywhere, usually 1,000 milligrams at a range of 500 to 1,000. So we'll just have a case that we'll get back to at the end. So this is a CKD patient who in June 2019 had a hemoglobin of 95, and we can see the patient is iron deficient. And the patient was, oral iron was increased to 600 twice a day, and patient RNS was increased to 30 microgram a week. In September, the hemoglobin dropped to 78. The patient is still iron deficient, and the RNS was increased to 40 microgram a week. And in October, the hemoglobin rose to 98, but in November, it dropped to 88. So the question here is, should we increase the RNS dose? Should we switch to IV iron or continue oral iron? And we'll get back to this case. Okay, looking at the comparison of IV iron products, there are three on the market in Canada. There's iron gluconate, which is for Lesed, iron sucrose, which is Venofer, and then the Ferric Derisomaltose. So the maximum doses for each of these agents differ. For iron gluconate, the maximum single dose is 125 milligrams. With iron sucrose, it's 300, and with Ferric Derisomaltose, it's 1,000. And we can see that for the manufacturer, the infusion rates for all these three products, they actually have their monograph. You can do much quicker, like IV Direct, over several minutes. However, in BC and the BC Renal, the maximum rate we can give iron gluconate is 125 milligram an hour. With iron sucrose, we give 100 milligram an hour for the first dose, so that's 300 milligram over 3 hours, and then 150 milligram for subsequent doses, so that's 2 hours for a 300 milligram dose. And with Ferric Derisomaltose, different from the manufacturer, in BC, we actually give a slower dose over the first 20 minutes, and then we increase the full rate until completion. So a 500 milligram dose is given over about 43 minutes, and a 1,000 milligram dose over about just over an hour. And we can see the cost. These aren't the actual BCR costs because we do get contract pricing. But since iron sucrose did go generic, we can see the cost is half of the other two. And that's why in our dialysis units, we recently all switched over to using iron sucrose. So what are the differences between the three iron products? So iron gluconate is the smallest molecular weight. It's the most weakly bound to its carbohydrate moiety, which means that it dissociates really fast. And that's why your single dose is 125. Otherwise, we'll overwhelm the system. With iron sucrose, it's got an intermediate molecular weight. It's more moderately bound. So it's moderate to fast appearance of free iron. And so our maximum single dose is 300. And with ferric derisomaltose, it's the largest, which was similar to our old iron dextran when it was on the market. It's quite a high molecular weight, very tightly bound. So you can get away with these higher doses. And as you recall, it's the free labile iron that causes oxidative stress and inflammation. So the three main adverse effects that we see from IV iron are anaphylaxis, Fishbane type reactions, and isolated symptoms. With anaphylaxis, we usually think of our old iron dextran salt, which initially did cause a lot of anaphylaxis or anaphylactoid type reactions. With Fishbane reactions and isolated symptoms, they're considered non-life-threatening. With the Fishbane reactions, which is the transient facial flushing, myalgia, chest tightness, and or joint pain, we can actually stop the infusion and consider reinitiating at a slower rate once the symptoms subside. But we typically actually just switch to another iron salt. For isolated symptoms, like if a patient just has a rash or if they have hypotension on its own, again, we stop the infusion and usually switch to another IV iron product. So just looking at each individual IV iron, for iron gluconate, so there was some literature back in 2002, 2003, which suggested that you could increase the dose of Verlicit to 250 milligrams given over an hour. However, the Vancouver Coastal never did this. We never changed our manual, preferential manual. But Fraser Health, in order to use another IV iron for their CKD patients, they did actually switch to using iron gluconate, giving 250 milligrams still over a slower time period of 2 hours. However, they had several Fishbane type reactions, severe gut and back cramps, burning in hands and feet. And as a result, they switched to iron sucrose 300 milligram. So likely this was all secondary to high free iron concentrations. So really the maximum you can give is 125 milligram per dose. So a repletion dose of 1,000 milligram would take 8 dialysis sessions or 8 weeks in a CKD patient. For iron sucrose, when iron sucrose first came on the market, people were using higher doses. The manufacturer does recommend max of 500, but people were, there's some nephrologists and hematologists ordering over 500. We had a lot of anaphylaxis that was reported in our medical daycare. They were constantly calling, actually me, in the pharmacy. And we had several cases of Fishbane type reactions. So in conjunction with Dr. Benny, who was the hematologist at the time, we reviewed all these cases and found that these reactions were occurring with the higher doses and given at higher rates. So we actually capped the dose at 300 milligrams, and that's why in BC we actually have this max. It's just from Dr. Benny and myself, and we maxed the rate at 100 milligrams per hour, and the phone call stopped. In 2018, there was a request from hematology. Likely, it was from the Cerner sites that were going live, mostly the Lionsgate sites, where I believe they were actually giving iron sucrose a bit faster, and they wanted to increase the cap at this maximum rate of 100 milligram per hour. So we relented. And we, as long as the first dose is tolerated, subsequent doses can be given faster over 2 hours, so 300 milligrams over 2 hours. There is some literature support for this. This trial, it's an older trial, but it looked at Fishbane type reactions, hypotension. And when 500 milligrams was given over 2 hours in a variety of renal patients, there was a 36% increase, 36% incidence of these side effects. Was 400 milligrams was given over 2 hours, there's 5.7%. And then the largest number of patients, 300 milligrams over 2 hours, they had no incidence. And really, I really get no phone calls about iron sucrose. So I think it's minimal now. with a slower rate. So a repletion dose for the CKD-PD patients, 900 milligrams, you can give it daily or weekly for 3 doses. And in our hemo units, we can give it over 10 runs, 100 milligrams. And finally, with the iron Ferric Derisomaltose, our hematology unit with Dr. Jensen, in conjunction with Sunnybrook, we started using this in 2019. And initially, they actually gave it at a slower rate, so 500 milligrams over an hour. But they found there was a lot of acute adverse reactions in about 20% of patients, especially within the first 15 to 20 minutes. So in conjunction with Sunnybrook, they lowered the initial rate over the first 20 minutes and then increased the full rate if there's no reaction. And this lower rate, they found a lower incidence of fish vein reactions, which Hilary is going to review later. So really a repletion dose of 1,000 milligrams of Ferric Derisomaltose is over 68 minutes with this new regimen. And if the total dose does exceed 20 milligrams per kilogram, or you have a small patient, or 1,000 milligrams, then it's recommended to divide the dose into 2 infusions given 1 week apart. So now I'm going to transfer over to Kevin Kwok.
Okay, so I'll be going over a couple of studies looking at Ferric Derisomaltose in a non-renal population and the CKD population. First one I'll be talking about is from Derman and colleagues in 2017, where they did an open label RCT looking at patients with iron deficiency anemia from many different causes, mainly gynecologic and GI causes. Their intervention was Ferric Derisomaltose, and they were given 1,000 to 2,000 milligrams IV. If they got more than 1,000 milligrams, it would be split up over a span of a week, and they would get either 1,000 milligrams, all would get 1,000 milligrams initially, IV over 15 minutes, and then a week later they'd get 500, 1,000 milligrams. This was compared to iron sucrose, where they would get 200 milligrams IV up to twice weekly, and they capped it at 2,000 milligrams cumulatively. The primary efficacy outcome was hemoglobin increase over 20 grams per liter from baseline from weeks 1 to 5. And in terms of percentage, they found that Ferric Derisomaltose had a higher percentage of patients who reached this primary outcome at 68.5% versus 51.6% that reached this outcome in the iron sucrose group. In terms of adverse events, this was numerically Ferric Derisomaltose appeared to have more, but in terms of statistical significance, this was not found. 22.5% of patients in the Ferric Derisomaltose group had adverse events compared to 17.3% in iron sucrose. In terms of serious adverse events, both groups had 0.6%, so it occurred quite, it was quite rare to have serious adverse events, and there was non-statistical difference between the 2 groups. Second study I'll be talking about was by Auerbach and colleagues, and this looked at the same types of patients with iron deficiency anemia, mainly those with GI and gynecologic etiologies. They compared Ferric Derisomaltose given at 1,000 milligrams initially with iron sucrose, where they received 200 milligrams IV up to 5 times for a cumulative dose of 1,000 milligrams within the first 2 weeks. The primary efficacy outcome was change in hemoglobin from baseline to week 8. And in the Ferric Derisomaltose group, it increased 24.9 grams per liter, and the same increase was found in the iron sucrose group. This is non-significant, and it was non-inferior between these 2 groups. Adverse drug reactions, there was 12.5% of infusions that had an ADR in the Ferric Derisomaltose group versus 12.8% in the iron sucrose group, and this was non-significant. Serious and severe hypersensitivity reactions were also similar between groups with 0.3% and 0.4% respectively. And so these 2 studies were looking at the CKD population, and they were both done by Banderia and colleagues. The first one was done in 2015, where they looked at 351 hemodialysis patients who had anemia, so hemoglobin 95 to 125, and they weren't iron overloaded. So they had ferritin less than 800, TSAT less than 35%. The intervention was Ferric Derisomaltose at a lower dose than what you see now, as this is one of the first studies that were first clinical trials looking at Ferric Derisomaltose. The first group had 500 milligrams IV given direct over 2 minutes, The second group had 100 milligram given initially, then 200 milligrams at week 2 and week 4. And this was compared to iron sucrose, where they got 100 milligrams initially, then 200 milligrams at week 2 and at week 4. The primary efficacy outcome was proportion of patients able to maintain hemoglobin between 95 and 125 at week 6, and they were very similar. So 82.7 versus 82.6% respectively, not significant. Adverse events, there were no p-values given, but numerically it looked pretty similar. There were 45% of patients in the ferric derisomaltose group versus 51% in the iron sucrose that experienced adverse events overall. Adverse drug reactions, which they attributed to IV iron, were similar between the groups as well, so 5% in both. And serious adverse events happened in 8% versus 5% in the iron sucrose group. The second study by Banderi and colleagues was in 2022, and this looked at non-dialysis dependent CKD patients with hemoglobin less than 110 and either ferritin less than 100 or ferritin less than 300 with a TSAT less than 30%. The intervention was ferric derisomaltose at 1,000 milligrams given over 20 minutes compared to iron sucrose with 200 milligrams given up to a maximum of 5 times within the first 2 weeks and a cumulative dose of 1,000 milligrams. Change in hemoglobin from baseline to week 8 was their primary efficacy outcome, and the increase was 12.3 grams per liter in the ferric derisomaltose group versus 11.5 in the iron sucrose group. This was found to be non-significant and non-inferior. In terms of adverse drug reactions, the differences between these two groups were not significant. So 4.7% in the ferric derisomaltose group versus 5.3% in the iron sucrose group. And serious and severe hypersensitivity reactions happened very rarely, 0.3% in the ferric derisomaltose group and none at all in the iron sucrose group. In terms of study limitations overall, as you can see, the majority of these trials had short follow-up duration, so it's hard to draw long-term conclusions from it. In addition, you may notice that some of them, the patients may have just finished or been in the middle of their iron sucrose course, so the labs may not reflect what intervention they received. There was also reliance on investigator interpretation for adverse drug reaction reporting, and it wasn't clear how they determined whether these adverse events were related to IV iron infusions, which might explain why there's such variability in the percentages of adverse drug reactions reported. And lastly, Karen went over the rate of administration for these IV iron products. And you'll notice that the rates that these studies gave ferric derisomaltose and iron sucrose were faster than our current BC guidelines. And so we decided to take a look at ferric derisomaltose here at VGH. We conducted a retrospective chart review between November 2019 and December 2021. We included patients who were on peritoneal dialysis, home hemodialysis, and non-dialysis CKD. They needed to have a minimum of 1 dose of ferric derisomaltose administered. We looked at data in the PROMIS and in patient charts and looked at labs at baseline and their closest value to 4 weeks post-dose. And this ranged from 1 to 5 months. We looked at monitoring in terms of their labs and their vitals at baseline, 20 minutes into the infusion and 30 minutes post-infusion. We used descriptive statistics and a paired two-tailed t-test where p less than 0.05 was considered significant. For our efficacy analyses, we included patients whose hemoglobin was drawn less than 1 month or over 5 months post-IV iron infusion. With this criteria, we only excluded 1 patient. For safety analyses, we included all patients irrespective of lab draw times. For our primary endpoints, we wanted to determine whether ferric derisomaltose administration led to changes in hemoglobin, ferritin, and TSAT. And for our secondary endpoint, we wanted to determine whether ferric derisomaltose administration led to changes in doses of ESA or oral iron, or in the development of adverse events. And so now I'll let Hilary talk about our results.
Thanks, Kevin. Overall, we had 61 patients that we included in the study, and they received 68 IV iron courses, which translated to 71 infusions in total. 57% of our patients were male, and the mean age was 71 years. The majority, close to 75%, were non-dialysis CKD patients, with most of the remainder being PD patients at around 25%. Only one patient was a home chemo patient. In terms of baseline medications, close to 60% were on oral iron to begin with. Around 53% of patients were on an ESA, with the vast majority being on darbepoetin as opposed to epoetin. Next slide. In terms of the ferric derisomaltose dose that was given, the vast majority, 75%, received a single dose of 1,000 milligrams, and the remainder mostly received one dose of 500 milligrams. There were a few patients who received two doses in a weekly interval at the 500 milligram dose or the 1,000 milligram dose. For primary outcomes, like Kevin mentioned, we looked through the lab parameters of hemoglobin, ferritin, and TSAT and compared post-IV iron to pre-IV iron. These labs were drawn a median time of 75 days or so after the iron was given. So that's around 2.5 months after the iron. And all the differences were statistically significant. So for hemoglobin, when comparing post to pre-IV iron, there is a mean increase of 12.6 points. For ferritin, a mean increase of 310 points, and for TSAT, a 10% increase. So there are improvements in all of these lab values. Next slide. For for secondary outcomes, we looked at the mean changes in dose for the anemia therapies post and pre-IV iron. As you can see, for all of darbepoetin, epoetin, and oral iron, there were decreases in the dose post-IV iron for all of these medications, but none of these reached statistical significance. And this might be because of low sample sizes. For example, for oral iron, our sample size was only 35. Moving on to safety, we looked at the safety over 71 infusions as our sample size, and there were 8 ADRs, or adverse drug reactions, in total. So close to 90% of patients had no adverse reactions, and this was noted explicitly by the nurse in their monitoring notes. The majority of ADRs were quite mild, including things like dizziness, headache, stomach upset. There were a few patients who had more severe reactions, such as right-sided chest pain, paresthesia, and hypotension. For the hypotension patient in particular, we focused on this to see if there were any issues there. This patient has a systolic blood pressure drop down to 96, but this was a less than 30% drop, and they were asymptomatic. They were sent home without any further monitoring or treatment. And none of our patients required any major interventions, and we also had no fishbane reactions in our study. Some limitations of our study, main one is its retrospective design. So along with that, there was a variable timing and completeness of the follow-up labs that were done post-IV iron. We also had a relatively small sample size of only 61 patients. In terms of conclusions, so the majority of our patients received a single dose of ferric derisomaltose, 1,000 milligrams, and this resulted in significant increases in hemoglobin, ferritin, and TSAT. It was generally well tolerated, with only 8 ADRs over 71 infusions. And like I said, no major interventions were required for any adverse event in this study. We do have to keep in mind that we administered the medication over 68 minutes for the 1,000 milligram dose, whereas other centers in Canada are administering over 20 to 45 minutes. So we might see some variability in adverse events when we're comparing across sites. In addition, after study completion, we actually had one patient who did have a more severe reaction, and this was one PD patient who developed rashes on the right arm that spread to the back and chest. And this occurred about 10 minutes after the infusion ended. But fortunately, there was no itch, no difficulty breathing or chest pain, and blood pressure stayed stable. They were treated with IV diphenhydramine as well as IV methylprednisolone. And within 1 hour, rashes subsided and the patient was sent home. So far, this is the most severe reaction we've seen within the renal program. Iron sucrose used to be our standard, but with ferric derisomaltose, there are a few advantages. First being that you can administer a larger single dose, which means that we can reach the iron repletion dose in a shorter period of time. This translates to fewer infusion clinic visits, which makes it more convenient for patients. And with that, with fewer infusions, there's potentially some preservation of the peripheral vasculature, which is important for fistula formation in the future. This is important for non-HD patients. Next slide. So the hematology program at VGH also has gained a lot of experience with Ferric Derisomaltose. And Dr. Jensen was kind enough to provide us with his safety data. So in his analysis, there were 170 patients, and this was 300 infusions in total. Similar to our program, most patients received the 1,000 milligram dose. That was a single dose. And within the 170 patients, 28 experienced 29 acute adverse reactions. The majority of these adverse reactions were mild to moderate in nature, with 9 Fishbane reactions, as well as 10 urticaria reactions. And within the mild to moderate ADR group, 7 had to have their infusions aborted. There are 4 patients who had severe ADRs, including 1 with anaphylaxis, 1 with urticaria and wheeze, 1 with severe back pain and a decreased O2 sat, and 1 with severe back pain and a blood pressure that declined to 80/60. All these patients needed to have their infusions aborted. So the hematology program took their safety data a step further and tried to see whether there are certain variables that were associated with ADRs. They looked at age, sex, dose, infusion rate, pre-medication, allergies, and any previous ADRs to other IV iron products. We were especially interested in the infusion rate variable, since there was that observation that patients on the higher rate tended to have more Fishbane reactions. As you can see here, patients who had the higher rate of 50 mils an hour had a 20.8% rate of adverse reactions, whereas the lower rate had a slightly lower rate of ADRs at 16.5%. This is not statistically significant. We also have to keep in mind that they grouped all the ADRs together for this analysis and didn't focus on Fishbane reactions. So if they had, perhaps we would have seen more of a difference. The only variable that was associated with a statistically significant difference was pre-medication. So there was a hematologist who prescribes IV hydrocortisone as pre-medication for every iron infusion, and he ordered 17 infusions. Of those, none of those patients had an ADR, whereas for the remaining patients, 18.3% did. So this was considered to be statistically significant, and it provided some food for thought that maybe there is a role for steroid pre-medication. That being said, 17 is a very small number. It's hard to interpret this data and make firm conclusions. In addition, pre-medication of steroids is not recommended by the Canadian Consensus Guidelines for IV iron, just because there's insufficient evidence to support it at this time. Next slide. So grouping all of our safety data together for renal and hematology patients at VGH, we see that our renal patients, they received a slower infusion rate for everyone, and there was a lower rate of ADRs compared to hematology. Even in the patients who had a slower infusion rate in hematology, they also had a slightly higher rate of ADRs. Across both programs, most ADRs were mild to moderate in nature. And while we didn't have any severe reactions, Fishbane reactions, or aborted infusions, the hematology group did have a few. Overall, around 16% of patients had an ADR across both programs. Next slide. When ordering Ferric Derisomaltose, we have to keep in mind that this is quite an expensive medication, so there are formulary restrictions in place. BCHA has restrictions that are outlined at the top of the slide, but since our patients are renal, I'll focus on the BC renal restrictions. BC renal does cover Ferric Derisomaltose for non-dialysis CKD as well as independent dialysis patients. The patients need to have an intolerance or poor response to oral iron supplements, as well as iron deficiency anemia, as evidenced by hemoglobin less than 110 and a TSAT less than 20%. And the total dose that they require must exceed 300 milligrams, which makes sense because if you need 300 milligrams only, you can go with iron sucrose. Next slide. To offset some of the costs of ferric derisomaltose, BC Renal does request that we apply for special authority, and this needs to be completed for every ferric derisomaltose order, so you do not get indefinite coverage for this medication. The BC Pharmacare criteria are very similar to the BC Renal criteria, but they ask you to be more specific. So if a patient has failed to respond to oral iron, this means that they have to have tried at least 4 weeks of oral iron, and you have to specify the regimen that was tried as well as the duration of the trial. If the patient's intolerant to oral iron, this means that they have to be intolerant to at least 2 different oral irons, and you have to provide the details of that as well as the intolerances. They also specify that we need to indicate that the patient is getting the iron in a setting where there's appropriate monitoring and where there's appropriate management of hypersensitivity reactions if they occur. Next slide. So going back to the case that Karen introduced at the beginning, again, this was a 76-year-old female in a kidney clinic. The hemoglobin is now low at 88, despite having darbepoetin dose increased back in September. And we see that the iron studies are below target at 0.13 for TSAT and 63 for ferritin in September. With this patient, we decided to give a dose of ferric derisomaltose, 1,000 milligrams. And the nephrologist also decided to increase the darbepoetin dose to 50 micrograms a week. Oh, can go back. And with this, there's follow-up labs that Karen will try to reveal, but if not, the hemoglobin went up to 130 in January 2020. The TSAT was 0.22 and ferritin was in the 200s. So we can see that we overshot it in terms of our therapies by giving both the IV iron and the ferric derisomaltose. So at that point, we decided to reduce the darbepoetin to every 2-week dosing. And for the iron, we reduced the oral iron to 900 milligrams a day. Thank you, and I'll hand it back to Karen.
Okay, so we're switching over now to IV iron and infection risk. Again, we'll start with just a short case. This is an actual case in our hemodialysis unit. Patient with a right CBC who the nurse notes there's redness and blisters around the CBC site. Patient has normal vitals. Cultures are taken and cefazolin is started. And the cultures do grow MSSA, so cefazolin is continued, but blood cultures are negative. The patient is on IV iron every 2 weeks, and the dose is due on the 2nd dose of cefazolin, and the nurse asks whether she should hold the IV iron in view of antibiotic therapy. So is there a risk of infection associated with IV iron? There's been several meta-analyses between 2013 and 2021 that showed mixed results. So I tried to find the larger one. So Lytton in 2013 looked at 72 RCTs on various settings, mostly hematology and mostly obstetrics and orthopedics. And they looked at IV iron versus oral or no iron, and they found an association that IV iron had an increased risk of infection. In 2019, Shin looked at 4 RCTs and 8 case controls, so over 1,800 patients, mostly in orthopedics. And they looked at peri-op IV iron versus no iron, and they found that IV iron had a lower risk for post-op infection. Shaw, in a smaller trial of 6 RCTs, primarily in the ICU, looked at IV iron versus no iron, found no difference in risk of in-hospital infection. And then he repeated a study, including these trials plus more in 2021. And he looked at IV iron versus oral or no iron in over 32,000 patients. And IV iron versus no iron, there was no difference in infection, but paradoxically, IV iron versus oral iron, he found an increased risk of infection. And specifically looking at the forest plot, we can see that there is a significant, difference that favors, that shows that IV iron can cause increased risk of infection compared to oral iron. The issue with these trials is that they use varied iron doses. There's variation in infection reporting. But I did find there were 5 CKD trials, and none of these trials showed a difference in infection rate between IV iron and oral. So if we do believe that there could be an infection risk with IV iron, is it related to dose? And most of the literature we have to look at is renal literature, because they're the ones that use higher doses of iron and aim for higher ferritins. So the pivotal trial was from 2019. It's a multi-center prospective open label trial over 5 years. And they looked at 2 groups of iron. One is called the high dose iron group, where they gave iron sucrose proactive 600 milligrams on month 1 and then 400 milligrams later, given as 200 milligram increments, as long as the ferritin was less than 700 and the TSAT was less than 0.4. And then they compared it to a low iron sucrose group, which is called the reactive group, where they got anywhere from 0 to 400 milligrams of iron per month in order to make ferritin between 200 and 700, and TSAT between 0.2 and 4. And both of these groups, the IV iron was held if they had active infection. So their secondary outcome was to look at infection episodes and hospitalizations. The results are that the median monthly iron dose was higher in the proactive group, so 264 milligrams versus 145. By month 12, the proactive group received about 2,000 more milligrams of iron than the reactive group. And looking at the secondary outcome, there was no association between infection risk with either iron dose, serum ferritin, or TSAT. And we can see here for hospitalization for infection and infection episodes, there's absolutely no difference between the proactive and reactive group. So IV iron infection, another trial, a big meta-analysis again in renal patients. This was an arm, this trial looked at RCTs, controlled trials, and observational trials that compared high versus low dose iron up to 2017. They were looking at their infection outcome. They found 4 RCTs and 8 observational trials. And they compared high dose, or greater than 400 to 1,000 milligrams of iron with the various iron formulations, compared to no iron, which or 0 or less than 200 per month. And we can see there is absolutely no difference in infection rates. So if it's not related to dose, is it related to ferritin? And this is the question of which came first, the chicken or the egg, because is the serum ferritin high because you have an infection? So is a high serum ferritin causing the infection, or is the infection causing inflammation, which is causing the high serum ferritin? So the KDIGO guidelines recently, well, not recently, but in 2006, they lowered their upper limit of ferritin to not exceed 500 in renal patients. And it still stays the same in after 2016. And they felt there was insufficient evidence of beneficial effects for levels greater than 500. They felt there were few RCTs, small number of patients, short follow-up to actually assess infection risk, and the meta-analyses were inconclusive. However, with this caveat, most renal centers still use up to 800 or up to 1,000 as our upper limit. In BC, we do go up to 1,000. Otherwise, we just would be using way too much erythropoietin, and probably at least 50% of our patients will not be able to be on IV iron, especially in a dialysis setting. So where did this number come from? This Hone is quoted quite a bit in literature. Initially in 1995, he actually started this kind of question of whether ferritin was associated with infection. He looked at a prospective observational trial of 13 hemodialysis centers, still a small number, but he found that serum ferritin greater than 500 was an independent risk factor for infection. However, 3 years later, he repeated this trial in 19 hemodialysis centers and found that serum ferritin was no longer a risk factor for bacteremia. And then there was this very large retrospective trial of the US renal data system up to 2012 and over 18,000 patients. And this trial found there was a signal for infection-related events associated with high iron ferritins greater than 800. So if we look back at the pivotal trial, we know that there was no difference in infection rate, and their average ferritin was 650, although they did go up to 700, allow up to 700 versus the reactive group. So we know up to 650 to 700 in our renal population did not show increased risk of infection. And then I just thought I'd talk about the DRIVE trial, which was looking at iron gluconate. And they basically wanted to see if you gave iron gluconate to patients that had a high serum ferritin, but low hemoglobin and low TSAT, whether you could increase the hemoglobin level. It was a multi-center open label randomized trial from 2004 to 2006. They had problems with recruitment, so they only ended up with 129 hemodialysis patients. 65 received IV iron and 64 no. And they looked at the ones who received iron gluconate, 1,000 milligrams. If their hemoglobin was low, TSAT was low, and the ferritin was between 500 and 1,200. And they compared that to patients who got no iron, and both groups got an increase in EPO up by 25%. And their secondary outcome was looking at infection rates. And the mean ferritin was 900 in this, with plus or minus 200 versus 591 in the no iron group. And they found that there was no difference in infection rates between the patients who received IV iron versus control, so 12.1% versus 15.1%. The problem with this, and this, which is why KDIGO kind of rejected it, is because it is a small trial and it did have a short duration of follow-up of only 6 weeks. So this was just a nice little chart that I found in Kidney Medicine from 2020. So looking at ferritin and IV iron and infection risk. So there's some RCT data and pivotal trials demonstrated safety of IV iron with ferritins up to 700. There is some conflicting data, like the DRIVE trial did show it was safe up to 1,200, but the lead trial and some other observational trials did show that there might be a signal for increased risk. And there's no data looking at greater than 1,200 for ferritin. So what about giving IV iron in concurrent infection? Well, there's actually no human data on the effects of IV iron on outcomes during active infection. There are animal trials that show worse outcomes in septic mice given IV iron. And the KDIGO does recommend to avoid IV iron in patients with active systemic infection. So why is that? In vitro, IV iron or iron overload may cause increase in bacterial growth of various bacteria. And it also may decrease your cellular immunity by impairing T cell function and impairing phagocytosis with ferritins greater than 650. So this is all in vitro data. So again, looking at this nice little chart from Kidney Medicine, they recommend that it's safe to administer IV iron if there's no signs of infection, maybe you have an isolated CRP or latent TB or minor localized infection. Consider holding the iron with moderate infection, example bronchitis or H. pylori, but to hold the iron if patient is actively infected with a serious infection, sepsis or bacteremia. So getting back to our case, should we give IV iron in this patient that has a wound infection or a line infection, but blood cultures are negative and patient has normal vitals? It was interesting because I was going on rounds and I just was ahead of the nephrologist and I thought, well, before I give the nurse the answer, because she had asked me this, I'll see what the nephrologist said. And we both agreed to the same decision that this was considered to be a minor localized infection and IV iron, we said, is no issue. I mean, you could argue that what's the big deal of holding one dose? It's true, but in this case, anyways, we gave the IV iron. So in summary, for infusion-related reactions, we can see the dose and rate of infusion is related to how tightly the iron is bound to that carbohydrate moiety. As a caveat, just never give IV iron as a bolus, even though their manufacturer says you can. Reactions can occur on first or subsequent doses, and it's often we can often safely switch to another IV iron salt. With Ferric Derisomaltose, we do recommend in BC to give a slower infusion rate than indicated in the monograph. It's demonstrated efficacy and safety at VGH, especially in our renal population, and it does have several advantages over iron sucrose. And for infection risk, I really think that RCT data has shown that IV iron is likely not associated with causing infection, at least with doses up to 1,000 milligrams and serum ferritin up to 700 to 1,000. But due to the possibility of worsening active infection, there's no trials looking at giving IV iron during a serious infection. The guidelines would still be to recommend to hold IV iron during a serious infection, such as sepsis or bacteremia. So on that, we'll take any questions, and I'll just go to stop share.
Thank you, Karen, Kevin, and Hilary. That was really a great overview. I had the privilege of being at one of these KDIGO anemia consensus conferences, and the iron and infection thing comes up. My understanding, or what experts were telling us, is that it's only gram-negative bacteremia, gram-negative bacteria that can use iron as a substrate for growth. And so if you were going to decide on an infection, the gram-negative would be where you would not use it, and all others. And that's an interesting observation, which of course isn't in any of the trials, but would be interesting to also reflect on, because apparently the biology is that it's the gram-negative bacteria that can use iron, and the other ones cannot. So that's why perhaps all of the conflicting data that you so nicely presented, it might depend on the type of infection.
I think the issue there, it's just all based on in vitro data, and
yes.
I don't know if you could logically do a trial looking at patients with with infection. Should we give IVI or not? Probably won't be an ethical trial. So I don't know if we'll ever have that answer, but I have you see some trials that some gram positives could be, theoretically effective as well. Yeah.
There are a number of questions in the chat, which I'm going to try and lump together, and some of it you've actually already covered. For the patient, so Dan Martinson was asking, for the patient that had their monoferric infusion stopped due to an adverse reaction, did the hematology group estimate the dollars wasted compared to iron sucrose?
This is all the information we have from Dr. Jansen. So I don't have an answer to that one, but I know they're still using monoferric exclusively in their hematology clinic just because of the ease of administration and single dose.
Yeah, and then there are some interesting questions. So I think many of us are aware of the IV iron improvement in cardiac function in heart failure literature. And so one of the questions is, in patients who have cardiac disease, or maybe specifically heart failure, irrespective of the hemoglobin, would one think about IV iron infusions?
And Hilary, do you want to answer that one?
I know at the cardiac function clinic at VGH, they are giving IV iron as long as the hemoglobin is less than 150. If the patient has iron deficiency, is
115 or 150?
150. Like if the hemoglobin is less than 150.
These are non-renal patients.
Right, but the cardiac trials are quite interesting because irrespective of hemoglobin, as you say, IV iron does show improvements in cardiac function. It is one of the treatments for heart failure. So it is interesting. I don't think that we've quite applied it to our populations yet, but it is interesting for us to think about irrespective of hemoglobin. And then Nadia was asking, since there are clear advantages for monoferric over other preparations, but we usually avoid it who have allergies to other meds. So do you think we can give it to these groups of patients?
Well, it's interesting because the monograph, that Hilary can comment as well after, like the monograph does say if you have multiple allergies. So we just, based on our experience with femoxetol, which limited it to initially to 2 or more allergies, we kind of went with that. But I think, it's one of those that you have to feel comfortable using it. In our group, we only had 0, 1, or I think one patient had a couple of allergies. I know, Hilary, if you want to mention what you're doing in your clinic.
I've been trying to avoid monoferric in patients who have had multiple allergies, like you said, severe allergies to medications, or they've had a allergy to another IV iron formulation. But we haven't had much experience in patients who have had multiple allergies.
I think the key is that we were scared. We don't want to lose this drug like we lost from femoxetol. So we're just being a bit overly cautious with it.
Great, thank you. There's no other any questions that people want to ask by putting their hands up. No, I mean, I think this whole notion of IV iron and infection, I think it's a lovely summary that that rainbow thing that you did. Like, I think probably one doesn't need to worry as much as we have. And I think the stop-start for people that need iron probably has led to more confusion than not. But I think, starting it in someone with a serious infection would probably be wrong, or not not valued. They probably couldn't use it anyways, right?
Probably their ferritins would be so elevated anyways that you
Exactly.
probably would give it anyways.
Yeah, but it's not, but the ferritins for a different reason. It's not because they're iron
Yes, of
overloaded, right?
course.
So I think that's one of the problems with some of the constellations that we use, because we're implying that ferritin is a marker of iron. We know it's a marker of inflammation, and then we kind of get conflated about what we're not going to do for an elevated ferritin that may be there for a different reason. But I think it is, oh, hold on, there might be one more question.
I have a
Scrolling.
question for Adira
Oh
though.
yeah, the HIF,
Sorry, okay.
well, this is, so she was asking about HIF PHIs, are they coming in the near future? I think that's a way bigger and different question than IV iron. They are going to be approved in Canada, or are approved in Canada, and the question is, in whom should they be used? And that's a much larger conversation. Sorry, Karen, you were going to ask a question?
I was just going to ask you, if you ever go back on the KDIGO, are the anemia guidelines going to be looked at again to increase the ferritin to up to 800 again, like they used to have?
Yeah,
because it's really an illogical
I-
lowering to 500, and I'd say nobody really can follow it, or else no one would. I'm saying, like, in our unit, half the patients would not be able to be on IV iron, and so in BC, obviously, we're not following it. I'm wondering if there's impetus to push it back up to 800 even.
Yeah, I don't know. I think that the anemia guidelines for KDIGO are being worked on right now. There's an output, there is an output of iron in the anemia consensus conference that's from, I think it should be either out for public review or already done, which talks about iron, all the different irons. I don't know if you've seen, so and then the next one that's coming is on, so I think in that they did recommend a higher ferritin, did they not? Yeah.
Good.
But yeah. Anyways, I guess we've got 5 minutes, and it's a snowy something kind of crazy Friday, so perhaps everybody would like the extra 5 minutes. Appreciate again the work and the thoughtfulness that you put into this presentation, and I think everybody, by all the questions, etc., we're certainly very interested in the questions and answers. The last question is there a maximum recommended dose of oral iron? I mean, I think the problem with oral iron is we're not sure. The bioavailability is so weird that it's maximum tolerated by GI and other, I think, would be the right answer for that.
Like the maximum we seen was in this patient. That's why we presented it 600 twice a day. Hilary, have you seen higher than that in or Kevin?
No, we usually go with ferrous fumarate 900 as our max before we move on to IV iron.
Yeah.
I think a lot of it's tolerance, a lot of it's compliance. I find if they're going to be non-compliant, it's usually the oral iron that they're not compliant with.
Yeah. All right. Well, again, thank you very, very much. And we'll await both updated guidelines from other groups, but also perhaps a revisiting of anemia guidelines in the context of the BC population and changing data as well. So thank you again, everybody. Happy Friday.